Welcome to the Macmillan Report. I'm Marilyn Wilkes, your host, and our guest is Jennifer Prah-Ruger, an Associate Professor of Public Health at Yale University. She has authored numerous theoretical and empirical studies on the equity and efficiency of health system access, financing, resource allocation, policy reform, and social determinants of health. These contributions are unified by an overarching interest in equity and disparities in health and healthcare, focusing on vulnerable and impoverished populations nationally and globally. Today we talk with Professor Ruger about her new book, Health and Social Justice. Welcome, Professor Ruger.
Thank you for having me.
What led you to write your book?
I was interested in addressing several social problems that exist that relate to health and how societies across the world organize or fail to organize to address health issues. Mm-hmm. Some of these problems relate to differences or disparities in health outcomes. Okay. So differences in under 5 mortality, differences in adult mortality or premature mortality. Changes within the ability to be healthy over time and the course of life. Also, different social problems related to health with respect to access to health care, differences in access to quality of health care or medically appropriate and medically necessary health care. The fact that there are differences in people's financial protection for their health. Out-of-pocket payments can be exorbitant for many people. And the lack of insurance to cover the cost of health care can be very problematic for individuals and also for societies because we shift those costs when they're not paid to others. They can cause individuals to be bankrupt. They can cause state governments to be strapped with expenditures. There's also great differences in how societies allocate resources to health. The United States, for example, that spends more than any other country on health care on a per capita basis, is ranked 74th in the world in terms of health outcomes. And then also questions about the norms and values that the citizens of any society have about health issues. And how that relates to the policy decisions that are made at the state and the subnational level. So these types of social problems or issues with respect to health were of interest to me in writing the book. They collectively organize around a concept that's discussed in the book called health capability, which is the ability to be healthy. Okay. So differences, for example, in health outcomes occur in any society, and you can't guarantee equal health. People are differentially predisposed to health based on genetic or biological factors. So equal health outcomes isn't a possibility in terms of a social guarantee. However, the equal opportunity to be healthy, or the ability to be healthy, is something that is a problem that we should think about addressing, and the access issues, yes.
One of the things you do in your book is you look at a variety of different current medical and health frameworks that are in place now, and then you kind of cite the problems around those frameworks. Let's talk a little bit about that.
Okay. There are a number of different ways or philosophies in which different societies tackle these issues. One approach on one end of the spectrum is to just let individuals be responsible for their health and their health care, and basically allocate health care and the resources for health, whether they be public health or health care prevention or treatment, through the free market. And so people's ability to pay, whether they have money or not, and their willingness to pay for health care is really the way to go. And that's really the framework in many developing countries, and has been the framework in the United States, although we do have a mixed system. On the other end of the spectrum is a more of a command and control that the government is entirely responsible for the health of its population, and a focus on outcomes like maximizing the health of the population, or the average health. Now there are issues with both ends of those spectrum and in between as well.
Okay, yes. And what country could you cite as having that kind of
So
framework?
on the more command and control is typically the former Soviet Union countries and this type of approach. So and then there's systems that are in between. The problems with those different frameworks are on the free market side or libertarian side. Of course, there are what we call market failures. There are lots of problems with healthcare that are different than other types of goods like chairs and tables and rugs. There are externalities with respect to healthcare. So we have infectious agents, or we want to make sure that people don't spread disease throughout the population, and so we have an interest in a social interest in people consuming healthcare that they may not be able to buy through the market, for example. There are externalities in the cost of health care. Even if people don't have health insurance and can't pay for it, they still need it. And so they get it, and so somebody pays for the cost even if that person can't pay. There are asymmetries of information or differences in the ability to understand knowledge. So that's why we have doctors and nurses and providers who have a wealth of knowledge and information about healthcare and are specialists, and individuals who are lay people and have a certain amount of knowledge, but certainly aren't as expert as a physician. So it's different from buying a pair of shoes as compared to trying to decide about a surgery or a treatment. So these types of failures in the market, and also the fact that healthcare is what we call a merit good, which is we need healthcare and we need preventative services rather than just desire them or want them. So these are the problems with that type of approach, which justifies or provides a motivation for much more of a government or societal role. On the other side, the command and control, or the more focused on the collective, doesn't take adequate consideration of individuals and individuals' needs. And the fact that the ability to be healthy is really something that all individuals need to be conscious of, and we need to be thinking about individual needs as well as the societal needs. So something somewhat in the middle, and a hybrid of these approaches is really where we want to be.
Okay, and you've developed an alternative to those frameworks. Let's talk about the health capability paradigm. So tell us about that.
So the health capability paradigm is sort of a shift in thinking about this. Health capability is an idea that, again, goes back to what I was saying earlier. It's more about the ability to be healthy or the opportunity to be healthy, which involves creating the conditions, external conditions and internal conditions for individuals to be healthy. So on the external side, society or our collective, what we do in our public policies, whether we create regulations, we create financing systems, we create delivery systems, we create public goods of medical knowledge and information, we regulate doctors and how they deliver care and whether they're meeting certain standards. These types of external factors, whether people have enough food and food policies and things like that, have a lot to do with whether or not you or I have an ability to be healthy. We have the chance to be healthy, and a regulation of our environment and things like that. But there's also internal characteristics. So people make individual choices. We make choices about our diet, about our lifestyle, about what we do. Do we exercise? Do we not? Do we take preventative measure?
Do we smoke or not?
Do we smoke or not?
Right.
These sorts of individual habits, and so in a concept called an individual health agency, which is our ability to achieve health goals that we value. Do we have the skills to do that? Can we make cost-benefit trade-offs or look at risks of our, and the benefits? Do we have the information and knowledge to do that? So this is at the center of this paradigm. And then it's a comprehensive approach that looks at specific policy areas to address the ability to be healthy.
Like what?
Like access to health care and access to preventative measures. And whether or not on the external side, there's a regulation of the quality and the appropriateness of medical care. Medical care has to be appropriate.
So in your paradigm, would everyone have access to health care? Yes.
Yes, but it's not just any old health care. I mean, poor quality health care can actually mean poor outcomes.
Sure.
And differences in outcomes, and this may be, part of what is driving these. And actually, overutilization of healthcare could be less healthy and more costly.
Sure.
And so some sort of recognition of that and regulation oversight of that is very important. Also on the financing of healthcare. We know from social scientific research that pooling risk across a large population reduces the cost of healthcare for everybody, and is more equitable and efficient in terms of financing healthcare. It also reduces these negative impacts of out-of-pocket payments or when you pay at the service, because people may not demand appropriate healthcare, and it may also cause them financial trouble down the line. So financial protection at the national level and equitable financing would be part of this paradigm. Also allocating resources more efficiently and equitably. I mentioned that the U.S. spends more than any other country, yet is ranked 74th in health outcomes.
Yeah, that is
that
amazing.
shows that there's a problem.
Right. Yes,
that
it
we're
does.
not allocating resources efficiently. And we also have millions of 30 million people who aren't even in the system. I haven't been in the system. So there's a disconnect there. And improving those allocations are important. And then the focus on the norms and the common knowledge in a population about this goal and this objective, because it takes individuals and it takes society, it takes groups of doctors, it takes the government at all levels to be involved in this. So I think better education and better communication about values and norms with respect to health and both individual health and population health are really part of this as well.
I believe that the financial aspect is probably the largest obstacle, I think, to many people believing that the 30 million people, for instance, that do not have health insurance, how is giving them health insurance going to impact what I am paying for my health insurance?
Yes.
How does your paradigm address that?
Yes. Well, we're paying for health insurance very inefficiently. And in many other countries as well. It's not just the American system. As I said, the out-of-pocket expenditures in many developing countries, for example, are very problematic. So ensuring health insurance through a larger risk pool, we know that the more people are in the pool, the more you can shift risks or shift the cost from people who are healthy to people who aren't as healthy, from people who have more money to people who don't have as much money. Throughout the population in terms of age, younger people do tend to have less utilization and costs, but older people have more. So if you have a long-term view and a comprehensive view about it, you can actually spread these risks and these costs more efficiently, and it can cost less for everyone on a per capita basis. There's also important efforts to look at the costs themselves and recognize that the costs are too high. For many different types of procedures and different parts of the medical care complex, we are more costly than other competitive countries, for example. And so diagnosing the underlying causes of those costs and doing very specific and rigorous cost analyses to really get at the costs and separate what things really cost from what we pay for them in terms of the profit margin, for example, is very important as well. So there's a number of different measures that can be taken.
The profit margin, I imagine, is probably very high in this country for the medical profession.
It can be in some areas, and in some areas it's actually low. There are certain health systems that are doing better with less, and so we have positive examples of ways in which better quality health care and medically appropriate health care can be provided at a lower cost. And so there are some possibilities out there, and there are some actually examples and proven of ways in which this can be done. And so it's scaling it up.
Okay, and your book has been out there for about a year now. I am curious to know how it has had an effect on public health and the medical frameworks. We know, can you cite some of the positive effects that your paradigm has had?
Well, sure. So in the area of health insurance, for example, it's been there's been involvement with the current health reform efforts focused on expanding health insurance.
And in fact, your book has been noted in a Supreme Court justice ruling. So talk a little bit about that too. That's that must be very exciting for you.
Well, it's been very interesting. The issue of health care being very different from other types of services and goods, as I was mentioning, buying health care or purchasing health care and purchasing health insurance is very different. And people tend to equate it with other types of services when that is not really the case. And so health insurance, there are reasons for health insurance that are important that cover these costs that we incur. And the costs that incur based on anybody could wake up any day and have an unpredictable health event. We can't predict when we're going to be sick or when we're going to be injured, or it's very hard to, certainly we've tried to. And so health insurance provides that protection. And actually there's a social benefit to health insurance as well as an individual one. And so the question has been whether or not we should have people purchase health insurance to protect themselves. But the question actually really should be, are we asking people to purchase health insurance to protect themselves and protect society in terms of the transfer of costs and the transfer of the different externalities from not having health care or having health care and needing health care that's not paid for, what we call uncompensated care, or shifting of the cost of care. And this is something that we know social scientifically occurs. And so the shifting of cost creates these inefficiencies in the system for which advanced purchase of health care or advanced protection can perhaps not fully eliminate, but certainly protect in some measure at the individual and the societal level.
Okay, and moving forward, what would you like to see happen, particularly in the United States in terms of health care?
Well, I think things are moving in the right direction. There are a number of different changes that are occurring in both the policy arena and the legislative arena, the new health reform law, but also in the private sector. So in the book, I discuss a concept called shared health governance, which is really about the idea that creating the ability to be healthy for all individuals and the population as a whole is a team effort. That we all have a role to play. The government has a role to play in these protections and regulations and oversight and investing in public goods like medical knowledge and regulating services so they're high quality and redistributing resources. Doctors and providers have a role in terms of providing high quality services. Individuals have a role to play in their own health, and that responsibility is collective, that we have individual responsibilities and society has a responsibility. And so it's not a Republican or Democratic thing, it's not a liberal or conservative thing, it's a human issue about the human condition, that we're all part of the producing of our own health even. So no individual benefits from the whole infrastructure alone. It's a collective and an interdependent and codependent exercise. And so to the extent that we're moving more in that direction, which I think is, we have an opportunity in America to do that because we have a strong individualistic ethos, but we also have some examples of where we've come forward for the collective. Our Medicare program is a very good example. And this gets to the issue of norms and values. Some people say, if you don't do anything, please don't let the government take over Medicare. But Medicare is a government program. So the disconnect that I was talking about in terms of what people understand and the values and what they know about our programs versus what is happening in policy, I think needs to be bridged,
Sure.
as well as recognizing this notion of a shared effort and a shared responsibility.
Very good. Thank you so much for being here with us today and sharing some of your work.
Thank you.
For more information about Professor Ruger, please visit our website at yale.edu/Macmillan Report. Be sure to join us again for another episode of the Macmillan Report, made possible through funding from the Whitney and Betty Macmillan Center for International and Area Studies at Yale.